Good. I think we can start now. Professor is getting online in a short while. So, okay. Good morning, everyone, and participants and panelists. Thank you very much for coming on board. We appreciate that very much. Welcome to this weekly clinical webinar for Kenya Healthcare Federation. My name is Dr. Anastasia Nyalita. I'm the Kenya Healthcare Federation CEO. And with me is a panel of experts in the subject topic. And I would like them to introduce themselves. Also with us is Dr. Amit Thaka, who is the chairman of Kenya Healthcare Federation. So I would like to start with Amit. If you could introduce yourself to the participants.
Thank you, Dr. Anastasia. My name is Dr. Amit Thaka. I'm the chairman of Kenya Healthcare Federation. I'm pleased to invite the panel to introduce themselves, led by some moderators who have been working very hard on the diagnostic and the lab side from the Kenya Healthcare Federation. Also, I'd like to welcome all the attendees who have logged in this morning on this very important topic on testing experience perspectives from the Kenyan laboratories. Thank you, the panelists, for spending this time with us. Thank you for sharing the experiences. And most of all, thank you for all the hard work that all of you have been doing in the scenes to keep our testing numbers up and, more importantly, accurate. So let me turn it over to the moderators. We have two fantastic moderators, Anthony Jakudol and Dr. Francis Karanja, to introduce themselves, and then maybe Anastasia, after that, the panelists can do self-introduction. So over to Francis Karanja first, and then Anthony Jakudol.
All right, good morning, everybody. I hope you can hear me clearly. As you heard, my name is Francis Karanja. I'm a KHF director and also in CAPI, and I also work for GSK. So I'll just take you through a couple of slides to just give you a highlight of what KHF is for those who may be new to the word KHF, and to give you a better understanding of the current testing environment and where we are. So maybe to the next slide.
Okay, Francis, do you want us to introduce the panelists first, or we do it at the next after your slide?
As you prefer, maybe the panelists can also be introduced. Maybe that will also be good.
Okay, cool. So yeah, so in no particular order, we will start with your co-moderator, Anthony.
Okay, good morning, everyone. My name is Anthony Jakudol. I'm the CEO and founder of Keton Consulting. Keton Consulting was in the laboratory space, especially on quality issues. So I'm also a vice chair of regulation and standard committee at KHF. We look at issues, regulation, standards, and quality. So this particular webinar is quite in sync with our committee activities. Thank you very much. So I'll be your co-moderator today.
Thank you very much. We will also move on to Professor Omu Anzala. If you could kindly introduce yourself, and thank you for coming on board.
Welcome, everybody. Omu Anzala is my name. I work at the University of Nairobi at the College of Health Sciences. I'm at the institute called Kavi Institute of Clinical Research. I do virology and as well as immunology. Thank you.
Thank you, Professor. Professor Matilu Mwau, if you could introduce yourself.
Oh, sorry, I was looking for my mute and mute. Thank you. My name is Professor Matilu Mwau. I'm a deputy director at the Kenya Medical Research Institute. My workstation is normally in Busia in Western Kenya, and I'm an infectious disease specialist. I'm a medical doctor. I work in the task force for coronavirus testing at the ministry, where I'm involved in providing technical specifications in terms of budgeting, and also involved in validations of test kits. But outside of that, I run large testing labs. So some of the data that you see come from my labs as a normal scientist. Thank you.
Thank you, Professor. We will go to Dennis Alela.
Good morning, guys. My name is Dennis Alela. I work with the Kenya Medical Research Institute. under the CGHR branch. I work in the DLSP lab, which is a diagnostic lab, and I'm an assistant research officer. We do a lot of intervention in terms of various viruses within the country, and we also act as a reference lab. Basically, we're in the forefront fighting coronavirus through testing, and pleasure to be here.
Thank you. And we have Dr. Michael Reed.
Good morning, everybody. My name is Dr. Michael Reed. I'm a medical doctor. I'm a clinical epidemiologist and a pharmaceutical physician as well. And I currently head medical affairs for Roche Diagnostics Management Center, South Africa, which is responsible for 21 countries in Sub-Saharan Africa. Happy to meet you all. Thank you.
Thank you, Michael. And Dr. Abubakar.
Good morning, all. I am Abubakar Abdullah. I'm a clinical pathologist at the Aga Khan University Hospital in Nairobi, and mostly in microbiology and molecular, and do some of the molecular testing for COVID as of now. Thank you.
Thank you, Dr. Ari. And just for the participants to know that this is a 2-hour webinar. We expect to have a part 2 of a similar webinar next week on Tuesday, depending on what may have evolved from here or any other topics that may not have been followed. Just a few ground rules. You have been muted to allow maximum participation on the webinars, and you have 2 options for feedback and questions. So you have a Q&A tab that allows for direct responses to your questions or comments, and the chat box that will be visible to all panelists and moderators. So this webinar will be recorded and uploaded to the KHF YouTube channel, and your feedback will not be visible to the others. So again, feel free, this is a safe space, but however does not replace professional help. For that, we have the number to call, which is SMS or call 1199. So that's it for me. I want to hand it over to Francis to take it forward, and then also the moderator now to work with the panelists. Thank you very much. Over to you, Francis.
Thank you. Thank you very much, Anastasia, for the warm welcome. Should probably take less than 10 minutes to just take you through introduction on KHF and the latest developments in COVID-19. Next slide. So basically, KHF is the health sector board of the Kenya Private Sector Alliance. It's basically comprises of very many organizations that deal with all aspects. But for health sector, we are the key representative within KEPSA. Next slide. At the onset of the COVID-19 crisis, we immediately realized we needed to reconstitute the way we work so that we can provide effective support in terms of various work streams. So what we did is that we set up a project management office that has 9 chairs within the respective committees, led by, of course, our chair, Amit Thakkar, and vice chair, and our CEO, heading in each and every of those aspects. But within the 6 particular areas, supply chain, ICT and mobile health, health quality, regulatory and standards, healthcare financing, partnership, and human resources for health, we appointed a chair to lead the work stream and give support to each of those areas. We also have a couple of technical assistants as well. Next slide. So in the current structure, we have the KHF Board of Directors, which has the executive committee, as I mentioned before, Amit Thakkar, Elizabeth Wala, and Anastasia. And under that, there are 3 major work streams. So we have the committees, as I've alluded to earlier. Then we have the special intervention groups, comprising of hospital CEOs, lab, critical care, infrastructure, medical gases, legal advisory, digital health, Revitalizing Health Kenya. And they come in at various points of assistance. But right now we also were embedded into the different MOH task force committees, such as the one we are talking about today, the labs one. And we have all those others you can see there on the screen. And this helps us to have a very clear private-public partnership with the MOH and also lend our support and our expertise where required. Next slide. So let me just give you a few minutes about the current status as far as testing is concerned. As you can see, Kenya is running at around 2,800 cases, and on the logarithm scheme, we seem to be more or less not tapering off, but at least the growth curve is not as steep. And we thank the government and all the ministry officials and the private sector for the interventions they've done to lead us to where we are as of day 88. I mean, if you compare it with South Africa, which you can see by day 94, they're at 46K, and many other countries there, you can see the curve seems to be more or less flattened, but is not quite there yet. So it's still something we keep on noting, and obviously is of concern to us. Next slide. This slide will just simply give you an illustration of where we are in comparison with our East African countries, and also a few of the African countries. As of yesterday, we had done about 98,000 cumulative tests since the first day it was reported in the country. But compared to some of our African counterparts like South Africa, Ghana, Morocco, we're still lagging behind. But given the increased ramped up capacity for testing, which the able panelists will speak to, you'll see that this position will soon change drastically. At the moment, we are about 2.9% positive rate, but in terms of tests per million subjects, we are at 1,800, which is not too bad, but we know definitely this number will go up in the coming days. Next slide. Again, this is simply to represent the cases by the geography and the testing data for Kenya. So as I said earlier, we have about 2,800 cases positive so far, and confirmed deaths are 85, with just one extra death yesterday. Recovered cases totally is 849, and total cases tests completed is 98,000. If you look at the curve on your right, lower right, it just shows you the positivity rate. And at the beginning, it was ranging between 3 and 2%. For a long time, it was there. Then late May, it seemed to have shot up to 4 to 5%, and recently even up as far as 6%. But overall, the positivity rate remains at about 2.9%. The other slide on your bottom left would indicate that Nairobi and Mombasa are the largest cohorts where this disease is being found. Next slide. This slide again represents the total number of deaths compared to the other African countries. And we are ranging at 2.96%, which is pretty high, but I guess given that we are doing more tests now, we should see it just either pan out, or we'll see a difference from what it is right now. Compared to other countries within Africa, we're still, I would say, within the median range. There's countries with as much as 4%, and that's Tanzania, which we don't have complete data. I know Somalia has 3.55, and you can see even countries in Europe and the US are much higher. So I would say we are pretty low compared to some of these other markets or countries. To the next slide. Yeah, that leads me to hand over back to Dr. Anthony Jakodu, who will now take us through the different aspects of the perspective from a Kenyan lab. So over to you, Mr. Jakodu.
Okay. Thank you very much, Francis, for that summary of how KHF operates, and then on how we've been going on with our testing in Kenya. Yeah, for today's session, we'll have around 5 panelists. So we are not going to go in any particular order, but I would like to start with Professor Nzala, just to give us a synopsis of how the testing has been done and how our strategy as Kenya is, and what the challenges are, the gaps, and all sort of stuff. Yeah, over to you, Prof.
Thank you very much. I don't have any slides, but let me just discuss. I think you're all aware that We are first of all talking about a virus that is at most 6 to 7 months since it was actually identified. We know having spilled over into humans maybe in June, July, or August, but well identified towards November, December. We are all aware that it's a coronavirus, and coronaviruses are not new viruses. Coronaviruses are very common in the environment. They occur in various species across a wide range of animals. And that's why when you hear us talk about corona, the 4 types of coronavirus, we call them human coronavirus, clearly an indication that we have a lot of non-human coronaviruses. So as a virus, as a family of viruses, these are not new, but as an individual new spillover into humans, that is quite clear, it's a new virus. But also let's take note that there have been 2 other spillovers into humans. The first one was in 2003, when there was a spillover of a virus that we called SARS-CoV. We are now calling it maybe SARS-CoV-1. The second spillover was in 2013, when there was a spillover from camels to humans, and that is actually MERS-CoV. And those of you who are attentive to what is going on in Northeastern might realize that our camels are now dying. We are wondering what is killing those camels, but so far what we have picked that it could be some form of a respiratory infection. We don't know whether it is MERS-CoV. Some of our teams are there just trying to look at that. Also to realize that there was another spillover that nobody talks about very, very early on. I think this was in 1989. If you go back in 1989, you'll actually realize that there was something that was called the Russian flu or the Asiatic flu. Now, looking back, we actually realized that this was actually a coronavirus, and this could actually be the coronavirus that has now become endemic in humans, which we actually now call the OC43. We actually believe that OC43, 1889, the Russian flu, this was actually a coronavirus, and this could have actually been the first spillover. This virus has now become endemic, and it's one of the 4 coronaviruses that are now common in human. Interesting enough, SARS-CoV was studied in mainland China and then Hong Kong, lasted about a year and a half. SARS-CoV mutated and attenuated, and there's been no identification of SARS-CoV-1 since 2013. I mean, since 2003. MERS-CoV 2012-2013, MERS-CoV is now endemic in the Middle East. From time to time, it causes mortality among the elderly and those who actually have comorbidities. Now, when the first case occurred here, although we had started preparing, we didn't have ability to test. So the first few cases were actually sent out of the country. But I'm glad to say that very, very rapidly, Matilu Mwau and his colleagues at KEMRI quickly moved in, and with support from donors, we managed to get kits coming in, and that was now the beginning when we established our own ability to test. I think Mwau will speak more about the various sites that are now been put in place across the country that have now also been certified, that are also have ability to, to test. And I use the word certified intentionally because we are now realizing that within the private sector, we have seen a mushrooming of various tests from various places. And these are tests that have actually not been validated and tests that have actually not been approved. And this is actually goes against what we call the best practice. The standard and what is known now and what we can call the gold standard is a use of RT-PCR, all right? Is a use of RT-PCR. And this is actually looking at the genome of the virus. We know that coronaviruses are RNA viruses, and being difficult to work with RNA, in order to be able to really even sequence or even be able to perform the test, you have to convert the RNA to DNA, and then that DNA is what then we use for amplification, using very specific primers to either the glycoprotein on the surface, the spike, or the nucleoside, the nucleocapsid. Other people have been also using the RNA-dependent RNA polymerase. So it depends actually on the setup you actually have. And there are two aspects. Mwau can run both high throughput as well as the real-time standard PCR. At my lab here at CAVI, because of the research we are doing, we are not involved in regular diagnostics. Our setup, we are only involved in research, and I can talk about what kind of research we have actually started doing. So you need to aim for the 3 genes. And let me also leave that to Mao so that he can explain when they talk of a positive, what does it mean? When they talk of a negative, what does it actually mean? And what are the issues of quality or quality control? So those are the molecular tests. The second aspect of it, and those are the issues that we are still grappling with, is serology. Okay, before I leave molecular testing, there's been an issue of testing, and more testing. And on many occasions, I've said, in a situation of an outbreak response, you test for a reason. And you want that test to really assist you, to inform you, to make decisions of how you are actually going to respond. We have got a lot of bashing because some of us are totally against what is going on about testing hotel workers, about testing individuals who just move around and they want to go to a hospital and get tested. It is a useless test, testing hotel workers. It is a useless test just going to a hospital setting to be tested, because then it means that you don't understand the natural history of this infection. A negative test now means nothing on an individual level. And these are the things that we want to be able to advocate for. But we can then say, in a situation of a hospital, you can then say we want to test inpatients. We want to test patients going for surgery. Then there's a good reason for testing, because that could be part of infection prevention control. So my urge is that as decision makers in this country and people who hold a big stakeholder, we must be able to approach this in the sense that we understand the natural history, and each test has a reason. Those are the aspects we really want to go. And we were with Matilu Mwau yesterday. We may not discuss this totally, but we have started looking at totally a new strategy of how actually we want to test in terms of informing the outbreak response, all right? Because when we went into this mass testing, to us, it was a total waste of resources, and we have wasted a lot of tests that would have actually been used nicely and differently to inform the disease outbreak. Now, having left serology, and I think that is what I want to set us up for discussion. When I leave PCR and molecular biology, I go to serology. There's an excessive push to move into serology. Very good, no problem. Natural history is critical. Is this a systemic virus, or is this a mucovirus? We must understand that. So some of the decisions you see us make and some of the pronouncements you hear us make is actually informed by the whole issue of where do you find the virus and at what point of time do you find the virus, all right? Coronaviruses are basically mucoviruses. They will start in the respiratory tract, the upper respiratory tract, go into the throat, move down and eventually affect the alveoli. And then they have also a propensity, maybe through some mechanisms we are not able to understand, but I believe just through a bit of swallowing of the secretions that come up from the respiratory tract, we find these viruses in the gut. You can find this virus in the gut. You can also find this virus in the stool. So you must understand that approach as part of the natural history. But the issue is that at what point of time, there's very little of it in circulation. And that's why you have actually seen, if you've been reading articles, there's a lot of variability in terms of this virus eliciting responses. So there are two things. For serology, you can use lateral flow assays to look for antigen. And you can look for antigen in mucosal secretions, no problem. You can also look for antigen in stool. You can also look for antigen in urine, all right? With the flow assays, I'll be hard pressed to say that you can look for antigen in blood because I don't think that there'll be enough antigen in blood for the lateral flow assay. But the issue is that we can then look for antibodies, IgG and IgM. Now, because of the minimal amount that transits through the peripheral circulation, but also because of the nature of it mostly being mucosal immunology, part of it is that it will take time to elicit any meaningful serological immune response, IgG, IgM. Mwau can talk a little bit about what he has done, but what I'll say that for us here at CAVI, the few assays that we have looked at in terms of serology, IgG and IgM are very, very confusing. Because in some patients who've been infected for 21 days, for maybe just 10, 11 days, you don't see IgM. You actually see IgG, all right? And that IgG is not also consistent. But this actually runs against our understanding of immunology, because we know very well in immunology that the immune response that comes first is IgM, and then with time, you undergo what we call immunological switch, and then you start production of IgG. So this variability is something that we really want to be able to understand as we validate these tests before we can actually tell you that yes, they can be used. But again, what do you want to use IgG serological tests for? Do you want to use them for diagnosis, or do you want to use them to tell a patient that you have been exposed and now you are maybe partially not susceptible? Those are the issues that we must be able to discuss as healthcare workers, so that should you put that test in your own facility, it is clear why you are actually using that test, and it is informed by the natural history. So I think let me stop here just to elicit some amount of discussion, but that is actually for us the direction and the thinking that has informed a lot of the issue about the molecular testing, but realizing the molecular testing is now the gold standard. Thank you very much, Jack.
Thank you very much, Prof. Anzala. I think you've really hit some key points home. And you've really enumerated the reason why we should test. We should not just be able to test for the sake of it, but there should be a reason in it. The approach also really matters, as you just said, and what a better way now maybe to also introduce Prof. Matilo Mwau, just to enumerate for us issues of the testing approach, the experiences they've had in Cambridge, and also on the issues of validation and verification that is also an ongoing debate in the laboratory subsector. Karibu, Prof. Matilu.
Thank you very much. I think I couldn't have put it as eloquently as Anzala has. I'm actually quite pleased because it captures a lot of the discussions that we have had in the last several hours, actually not even days, with regard to the testing strategy. And because you are seated on the other side, maybe it would make sense for me to first bring you back quite quickly, and then we can work together. So if you look at the initial phase, when our problems began, when the rain started beating us, I would say, we began by testing all those who are in quarantine and those who are in isolation. And then we asked them for their contacts, and we began to round those ones up, and we began to test them. And we also tested those where we thought the criteria for COVID infection was met. And those contacts that you are looking at, with the experience of my colleagues, tells me that most of them were okay, and they remained okay, and we locked them up, and we tested them again, and they were okay, and they went home. The only difference at that time was that they had big bills, and they were making a lot of noise, and some of them are actually partying inside the lockup. Then the second phase was where we began to talk about targeted testing of large groups of people, where we thought community spread had occurred or had been established. For instance, the old town in Mombasa, Isili, Kawangware, Ruaka, etc., and so on. And we also tested medical workers. And because as people are downstream in the whole story in the lab, we could see what you are doing upstream, testing medical workers. And then very recently, you began to ask to test restaurant workers. And I can tell you very quickly that some of them were tested using the various mechanisms, some in the private sector, some through the city council operations in Nairobi, and some of them actually came to our labs. And it was extremely difficult to find a single positive restaurant worker. It was very, very difficult, okay? Then there was the issue of truck drivers and entry points, and you could see the commotion that occurred as we tested long distance truck drivers. Our yield there was much better than the yield with regards to restaurant workers. So the truck drivers thing was probably well thought out, okay? And again, we continue testing contacts of those who are determined to be positive with the mixed findings, but mainly very well people, and some of them also very difficult to trace and capture. Then now, thinking through this, we came to the conclusion with our colleagues that perhaps we needed to rethink the testing strategy, and we needed to start thinking about testing for good reason. These PCR tests are extremely expensive, very, very expensive undertaking. Every time you look at the budget and you see how much people intend to spend on PCR tests, you shake your head and think, oh, this could be the economy of Chad, or maybe Chad has improved, but the economy of a small country. So going forward, there are things that we must think about with regard to the testing strategy. Maybe we need to think a bit more about those people who are presenting to health facilities with signs and symptoms that are suspect, that might meet the criteria for coronavirus infection. Of course, we have to think about truck drivers because they need to continue crossing the border, and the migratory nature of truck drivers and their habits pose a public health risk. So overall, we need to think about those people who pose a public health risk, and that includes truck drivers. Healthcare workers are generally safe, in my opinion, except when they meet the case definition. They use their PPE nicely and so on. As people in the lab are at a very high risk because you're working with live virus and you're not working with one sample. You're working with many samples, and unfortunately, patients are also coming to see us so that we can test them. And some of them are people we can turn away, but there is one or two that we can't turn away for some reasons that you might think about. And then, of course, there are prison remandees because of the nature of the incarceration. Those are people we need to think about when we are thinking about this testing strategy going forward, because they amongst themselves pose a public health risk. Now, with regard to testing laboratories, the capacity, you've heard so much about testing lab capacity. There's been a lot of noise. Oh, we are totally incompetent, incapable, and so on. Let me tell you, as of today, there are 25 laboratories that are involved in coronavirus testing in Kenya. You need to be aware that in Kenya, labs are quite familiar with DNA or RNA PCR testing. And this familiarity comes mainly from HIV, but is not limited to HIV. It also includes many other viruses. For instance, in 2019 alone, just 7 laboratories, in 2019 alone, 7 laboratories did 1,700,000 viral load tests in the public sector space. And they did that with relative ease using automated equipment. And I saw in this forum, there is somebody from Roche, and the main equipment at that time were Roche and Abbott. Currently, coronavirus testing follows more or less the same procedures as HIV testing in those laboratories. Now, as of yesterday, when I checked, there are 10 laboratories that have high throughput that are involved in this business, and there are 15 laboratories that are either medium or low throughput. And I was just doing the calculation this morning. The machine capacity for these labs, if you run those machines at 24-hour shifts, as in without stopping for a particular day, if you did that, the tests exceed 40,000 per day. For HIV, if I take you back, the automated labs were doing about 7,000 tests a day on average. Of course, some days they were doing 10,000, some days fewer, because test kits have always been a problem in terms of supplying, not just for corona, but for HIV. So this year alone, we expect the average number of HIV tests in a day to be about 6,900 or 7,000, okay? So the workload for these labs is well established already, but they normally operate at very much below capacity, all right? So we have skilled human resources in these labs. DNA and RNA work is not work that can be done just by somebody who has been there for 2-3 days. These are skilled resources that we have, and we are only limited in terms of the numbers of humans that we require. And of course, I just participated in a Global Fund budget recently, and that matter of human resources came up, and I was in a government meeting last week where that matter also came up. We think the gap probably exceeds 122 staff. But anyway, we should assume right now that the labs are just 50% staffed, okay? And at that level of staffing, we should even assume that the existing technologies can even do just about a quarter of the capacity that they are capable of. If we say that, this allows more than 10,000 tests per day without breaking a sweat. And if I bring you back, I want to remind you, the maximum number of tests we've ever done in any one day was about 3,800, if I remember correctly. And the other thing about that is that you were told in a previous presentation, 2.9% of the tests are positive. And it seems to me as though our virus behaves in a more or less arithmetic way, because even when you increase the number of tests from 1,000 to 3,000, we still find around, on average, around 2.9%. and so on. And even if we scale up in the near future, unless we do something really ridiculous, I don't expect this to go above maybe 5-6%, okay? Now, with regard to testing kit supply, this is where our problems are. You know very well there has been a massive failure in the marketplace to meet the demand for commodities for this response. And this failure is not only with regard to diagnostic commodities, it's also with regard to protective equipment and infection prevention control materials. Complete failure. But the manufacturers actually have a point. They are facing overwhelming demand from the current epicenters. And they are required by their governments to first meet their local needs before they even think about us people out there in the periphery. In any case, most countries are making orders. Some of them are quite ridiculous, actually. But in any case, what that means is that they result in an allocation problem for the production that these sort of manufacturers of the big equipment are able to supply. I know that in March, the WHO worked together, UNITAID and World Bank and UNICEF and CHAI and Global Fund and so on, to rally everybody to a common platform, a consortium of funders that would allow some ring fencing of the test kits that people like Kenya need, so there would be a bit of equity. But the last time I checked, that consortium seemed to have collapsed and died a natural death. And then, although the availability of the kits from the big manufacturers is quite greatly challenged and diminished, there are some other manufacturers from other parts of the world, like China, Korea, and so on, the manual ones, the manual testing kits. Those ones appear to have been able to be up to the task because they seem to have managed in some places to close the gap significantly, and that's what we have relied on in Kenya. Now, coming to the specifics, so far, the last time I checked, Kenya has procured about 130,000 tests since the pandemic began. That figure may be off by a few thousands. Of those 130,000 tests, that 2,000 tests were for automated platforms. That's as much as we could get, although we asked for hundreds of thousands. So far, we only got that. supplied like the way you supply pills with the medicine. And then 98,000 tests were for manual platforms. And now the second thing that you must think about very carefully, the last time I checked yesterday, all the tests that Kenya has procured have actually been from other people and not from Wanjiko money, from Chai, from JACMA, from World Bank, from Africa CDC. Although we are expecting 180,000 automated tests on Thursday this week, that's Abbott test, 180,000. If they are delivered, then that one will be a government procurement, and I'll be quite pleased that actually now Wanjiko is having the money spent that it should be. And we have made a new global fund application where we are expecting another 236,000 tests. So as of today, there are about 30,000 tests in stock, and there's a backlog of about 8,000 samples. I must tell you this because outside of this meeting, people will call me and tell me, our results are not ready and so on. We hadn't tested for some time, and we have a backlog of about 8,000 samples. We have 30,000 new tests that just came in yesterday. The stock, after doing the backlog, the stock that will be left with can do about 7 or 6 days, okay? At the speed we've been testing. What we project, this is where the trouble is, because I have to rely on the team that is being managed by Anzala with regard to projections, and the figures I get are very, very scary. Okay, so let's think like this, first of all. In the worst case scenario, and I'm quoting Anzala now, in the worst case scenario, up to 88% of us people will be infected in the period between when the coronavirus started to January 2021. But in the case, if we look at the way the virus is behaving amongst us right now, then maybe 68% of us will be infected between the time this thing started up to the time, up to around maybe early next year. So in that scenario, it means that about 360,000 people will have moderate infection, and then about 115,000 people will have severe infection by around early next year. And now for us in the testing laboratories, we must imagine that these people will receive a minimum of 2 coronavirus tests. The one that says you are positive, and at least the one that says now you become negative, and there could be another one in between, okay? And in fact, sometimes you require that there are 2 negative ones and so on, but I can see the WHO regulations are changing. If that is the case, then we will expect to be testing somewhere between 3 and 5 million people. We'll have to deliver 3 and 5 million, somewhere between 3 and 5 million individual tests, or double that, up to 10 million, 2 tests per person kind of approach. And I've not even counted truck drivers and remandees and other special populations who need to be under constant surveillance. So if we are looking at 10 million tests, let's go back to the lab, what I told you, that if we look at 25% instrument capacity being used for coronavirus, around 50,000 tests a week, that could amount to 2.6, maybe 3 million tests in a year if you push these things a bit. And the gap will be about 7 million tests, which now brings me to what we should actually do. We must look very carefully at the rapid diagnostic tests. So far, the information we are getting from the validations we are doing is very confusing information. There's some rapid test kits. If we take them out to Nairobi right now, more than half of the population will be positive, and there'll be riots in the streets because there'll be nowhere to take them because of this habit of locking people up. Maybe we'll need to use rapid test kits in an algorithm. We must admit that they're improving a little bit. Now it's not as bad as it was in March in terms of performance. They're improving a little bit, but we need to think the way we thought about HIV from the beginning. We cannot do 10 million PCR tests in this country just like that unless we stop everything, we stop growing even Sukuma Wiki and focus on PCR tests. Now, the other thing we could do is pool samples the way they did in Wuhan when they wanted to test 11 million people. First of all, they used saliva. They didn't put the nasopharyngeal and oropharyngeal things, and they pulled families together into one saliva container. Then if you are positive, they come and find wherever you are from the remnant samples. Maybe we should think about that in Kenya. I think the only other thing I want to tell you is that if you pool samples, you could get false negatives because like you are diluting, unless you pull just a few of them, that improves that problem. The second thing is that you'll always find positives, as we say, that as an understood result. Negatives, some negatives can be false, even positives can be false, but you can also have indeterminate results, especially if you keep samples beyond the the time that you should in the conditions that you shouldn't. For instance, if we keeping 8,000 samples as a backlog, and then we go and test them, we might start finding indeterminate results and so on, but we know how to fix that, and we know that most indeterminate results are positive. That's where I want to stop for now. I hope at least that builds the conversation, and thank you very much.
Okay, thank you very much, Prof. Matilo Mo. I think you've really brought out the issues that we are facing as a lab fraternity, also as the testing community. So you've talked about issues of economical impacts of the testing. We should be able not to just test everybody, but the testing strategy needs to be as crisp as possible so that we are able to see the desired results. And the continued about 2.9% positivity rate for the test that you are testing, for the sample that you are testing, regardless of the numbers, is also quite telling, as been shown in your particular presentation. So I also like to bring another panelist on board just to give us a punch on what's happening in the lab. One of my panelists is working actually on the samples on a daily basis. You should be able to tell us also the challenges and also the issues around molecular testing. As Prof. Matilo has said, on issues of skilled personnel in terms of testing for molecular, we should be able also to be top-notch and up to speed on that. So on this particular juncture, I'll bring on board Mr. Dennis Alela, who works with Cambridge CDC, just to give us some highlights about his experience. Karibu, Dennis.
Afternoon. I think Prof. Omu and Prof. Matilo have basically captured almost anything that I can add. But basically, I think what we've seen is with the high number of samples coming in every day, one of the major challenges we faced earlier in the testing phase was sample accessioning, whereby the way they're collected and transported to the labs, all mixed up and with the forms, and you have to check if what is collected is the correct thing and whatnot. But we are lucky in Cambridge, we have a SMART center, whereby it's a sample repository building. So they've actually helped us, since all samples go there, then they sort them out and then they direct them to each and every lab for testing. One of the major challenges is due to the nature of work, the way it's set up and the numbers that are coming in. Remember, Professor Mwau said that not every lab is fully automated. So most of the assays sometimes we do are manual, whereby you have to extract manually to get the RNA before you set up your PCR. And with that, it poses a lot of challenges when you're working on a high number of samples. Sometimes fatigue sets in and it's hectic work. But we are glad because for us in our lab, actually, we have a semi-automatic platform whereby we can get RNA in 1 hour's time for like 96 samples. So it's really isn't the burden of work for us. But I think overall, the experience is humbling. It's too much work and we're not complaining, but basically, there's nothing much I can add. Professor Omu said it all, then Matilo also said it all. Yep.
Thank you very much, Dennis. I wanted to bring them together on board from the public sector, especially from Cambridge has been maybe the major source of testing in this country, and also on the case management side, that is Professor Nzala and the team. So I would also like to bring the punch from the private sector. The private sector have also been involved from the beginning. I remember most of us are in the task force, or we are embedding the task force to be able also to give the perspectives from our private sector as a whole. So I would like to bring on board Dr. Bubakar from Aga Khan Molecular Laboratory. He should be able just to take us through his experiences dealing with the COVID samples and also issues to do with the quality and all those kind of stuff. So Dr. Bubakar, you're much welcome, and you should be able to also give us some punch.
Good morning again, all. So thank you, Prof. Nzala, Prof. Mwau, and Dennis for sharing your experiences. And before I go to our experience at Aga Khan, I'd actually prepared a small presentation just as an overview of the testing techniques. I've been asked to talk about the testing techniques that are available to us currently. And so a short presentation talking on the same. Let me just share my screen. You able to see my screen?
It's okay. We are able to see
Yeah.
the screen. Okay.
So we had talked about, we presented the numbers currently as there, and as of this morning worldwide, we had about 7.2 million, and so far about 409 deaths. And our numbers in Kenya, so far we've had a total of 2,862 with 85 fatalities. And these are the numbers as of yesterday that were announced yesterday. For SARS-CoV2 testing, we know that lab testing is needed to confirm cases that are suspected or probable cases. And from time to time, from the time we had our initial case here in the country, in early March, the decision is to be guided by the clinical and epidemiological data. Of course, both will define the suspected or the probable cases. And as we know, the virus can be detected from a range of specimens, but it being a respiratory virus, respiratory samples give the greatest yield. And what we've been using so far as the nasopharyngeal swabs and oropharyngeal swabs for ambulatory patients and patients with more severe respiratory disease where nasopharyngeals and oropharyngeals cannot be gotten, a lower respiratory tract sample can be collected, but care should be taken there in terms of infection prevention, because aerolization is much higher in these guys, in this set of collecting either tracheal aspirates or bronchoalveolar lavages. In terms of the ambulatory samples also, I don't know, the other panelists can also comment on usefulness of other samples, because we've seen studies coming out saying that saliva can also be used, or nasal swabs, nasal tabinet swabs can also be used, which would be much simpler samples to collect as compared to nasopharyngeal swabs. So PCR, as Prof. Nzala had said, is a diagnostic test to be used. And there are a number of PCR assays available, from lab-developed tests to commercial open test and closed proprietary test platforms. So the closed proprietary test platforms will include platforms like the GeneXpert or the Roche, where the reagents are specific to the system or to the platform that you have. And usually what happens is the extraction and amplification happens in the same setting. All you do is just, the hands-on time is very little, and put on the specimen and you get your result after a number of hours, depending on the system that you have. For the open commercial systems, this is where you have different, you can use reagents across. So you do your extraction, and after the extraction process and hybridization with the enzymes, then you put it on a thermal cycler, then get your results after some point. So we've had testing across this, from open commercial systems to closed proprietary tests being used in the country. And at Aga Khan, so far we're using the Rotogen platform with extraction happening outside, and we use the Altona kit. And just a reminder of the structure, the M protein, the S protein, the spike protein, and the targets. Part of the structure that is of interest are the NES or F1 and ACTI. And these are the genes that so far have been targeted, and the different PCR kits have different targets. And these different kits also have different diagnostic accuracies. And that's why you need to validate or verify what the manufacturer has given you at that particular point. And at least you should know the performance of the kit that you procure. And then you can interpret the results that you get from the kit. And at least, so the different kits have at least two targets. One target is usually specific for your SARS-CoV-2, and one target is specific to the beta coronavirus group. So this includes also the SARS-CoV-1. Okay? And a positive case is called by positive amplification on 2 targets, of which at least 1 target is preferably specific to your SARS-CoV-2. And this is something else that the other panelists can also comment on what how we will get a uniformity across the different labs that do the testing in terms of what we call a positive case. So, because there are cases where we'll have amplification on only 1 gene target instead of the 2 gene targets. So then how do you report that out? Is it that we stick with everyone doing the testing should stick with what the manufacturer of the particular kit you're using says, or is there one uniformity that we should be doing this with? Then one major aspect of the PCR kits that are out there currently is the false negativity rate. The specificity is not 100%, but it's pretty good. The sensitivity is what varies majorly between the different kits. And so you can have a lot more false negatives compared to what you'll have as your false positives. And the false negative can be due to a variety of reasons. So one can be poor specimen quality because you have little patient material in it. And so you'll need a control, add a human target in your PCR. Or it could be too early in the incubation period where the virus is not yet detectable. And so the specimen could also have been collected too late in the infection when the viral shedding has gone down, so it can give you a false negative, or poor specimen handling and transport. So if the VTM is not good enough that you've used, or it's not been used, or it's not been transported in the right temperatures, and you have you lose the RNA that you had in there, or technical reasons that are inherent in the test itself. Yes, if at some point we do get a viral mutation that is not, so the target genes have mutated, so your test cannot pick up the virus in the test itself. And so all your PCR runs should include some controls, positive and negative, and an internal control as well. And for good lab practice, all laboratories should participate in some EQA scheme, or at least an interlaboratory comparison, so that you know that across the labs that are reporting this, there is some uniformity. Going to serological testing, so serological tests basically detect the presence of antibodies against SARS-CoV-2 from a blood sample, can be serum or plasma-based, or even whole blood-based. And as we know right now, your IgM response and IgG response starts at about day 7 to day 8 past your infection or onset of symptoms. And so you can have this period of time between day 0 and day 7 where you'll actually get a negative antibody test if you are to do an antibody test on these patients. But at that point, the patient is infected. And the types of serological tests we have so far are binding antibody detection tests, and this use purified proteins of your SARS-CoV-2. So you don't use live virus. And so this can be done at lower biosafety level laboratories, including your biosafety level 2s. And they can come either in the form of a POCT, which is a lateral flow device, or it can be laboratory tests in the form of an ELISA or a CLIA. And then you can have neutralizing antibody detections. And so this determines the functional ability of antibodies to prevent infection of the virus in vitro. So you're using a whole virus, and this can be viral neutralization tests. And this should only be done in a BSL level 3, because you're using the SARS-CoV-2 virus from a clinical isolate or recombinant SARS-CoV-2 virus. Or you can have a pseudovirus neutralization test. And depending on the recombinant pseudovirus that you're using, this can be run at a biosafety level 2 or level 3 lab. As of now, only binding antibody detections have gotten FDA approval to be used. No neutralizing antibody detection test has been given FDA approval. So antibody tests and serological testing measure exposure to your SARS-CoV-2. And so they'll be useful later in the course of illness, as we have seen, and after the body has initiated an adaptive immune response. So still, as Prof. Anzala had said, this is a virus that has been with us for 5-6 months. There's some things we know, and there are things we still don't know. We've seen that the response, you can pick up IgM, IgG from day 7, day 10, thereabout. but we don't know how long these antibodies last in the body yet. We don't know if this immunity is protective and for how long it is protective, at least in the patient, in the body. We've seen some in vitro studies, we've seen studies in monkeys, and that these antibodies are actually able to neutralize the virus, but we've not been able to show that directly in patients. And what level of antibody is actually protective, if they are protective, and these are things that are still being studied. So in general, what does this mean? It means that there is limited utility so far from what we know. A negative test does not exclude active infection because it could be in the early phase of infection. And a positive test does not provide information on active infection or whether one has actually cleared the whole virus, because you could still be, especially in the patients with severe disease, they could have a positive antibody serology, but they also have circulating virus still, or virus, they are still shedding virus. And anti-SARS-CoV2 antibodies detected by serology may actually cross-react with antibody responses from your seasonal non-SARS coronaviruses. Yeah. So currently, serological testing is not recommended for the diagnosis of COVID-19 infections, and the gold standard remains to be molecular testing. But it has some utilities, and some of the utilities include surveillance of the disease to determine the spread of your COVID-19 so far, because there are asymptomatic patients who will not present, or even mild diseases that will not present for testing, for your molecular testing, and that will be missed. And knowing how far the disease has spread, or at least incidence at that particular point, it informs what you can do in terms of public health interventions. And then it also provides data for the study of the immune response, which will inform the development of vaccines. It will be able to tell you, serological studying or antibody studies will be able to tell you what particular antibody neutralizes, is a better neutralizer of the infection of the disease, of the virus, and that will inform the development of the vaccines. And you can also monitor immune responses to select your candidates for COVID-19 vaccines and vaccine development, and also treatment options, including identification of potential donors of your convalescent plasma. And in terms of the antibodies, there are certain special groups, including your elderly and the more immunocompromised patients. There's still studies going on, but so far it's been shown that they may either never develop the antibodies, or they develop them much later as compared to the general population. Yeah? And asymptomatic infected persons thought to have low antibody titers than the infected symptomatic individuals. Therefore, they might have negative tests sometimes, dependent on the limit of detection of the assay that you're using. So there are varied serological kits available. There's difference in performance in these kits, and that's why it's important that you validate or verify before use of these kits. And there's already data on performance of the different kits available from the FIND organization. And if you go to their site, they actually they've compiled different kits and the performances of different kits, looking at the sensitivities and specificities of the different kits that they're verified. And there's actually a lot of serological kits, I think like 100 or so serological kits that they've looked at. And there's also the FDA EUA approved kits that are available on the FDA site, and their performances in terms of the sensitivity, specificity, and the PPV and NPV. I think that's the end of my presentation.
Okay, that's a very powerful one from Dr. Bokar from Aga Khan. I think he's been able to touch on the testing infrastructure for COVID. He's looked at issues of molecular testing, and he's dived deep into details on what that entails. I think most of you have really been curious about serological testing, which I think we still have to treat with caution based on the data. It's just maybe shared with the participants. So at this particular juncture, I would like to introduce one of the vendors in the market, manufacturer of kits, so that we are able to have that mix between the users and the manufacturers and all those kind of stuff. So we are privileged to have Dr. Michael from South Africa. He's the head of medical affairs for Roche. Roche has been a platform that has been used for this particular fight since the beginning. together with Abbott. So he should be able also just to tell us how the journey has also looked like and how it is. Karibu or welcome, Dr. Michael Reid.
Great. Thank you very much, Dr. Anthony. I think what I'll just go on to share my screen. Just go. Yeah, so I know it says yes, anti-SARS-CoV2 serology. I think when we spoke, we talked about how the serology is coming in, and there's a lot of discussion. I think Prof. Anzala, raised a lot of issues around it, whereby it's not really clear in some, instances, in terms of our general immune response to COVID. So what I'll just do is I'll just take this opportunity just to, walk us through in general terms, on some of the data points around the COVID testing, from and giving a little bit of a Roche perspective as well to it. In some of the instances where the discussion has already been clearly outlined by Dr. Abubakar, I'll just rush over that so that we don't waste time on that. Okay, so right. So basically, I think this is what the outline I'll go for in this discussion. But just to start off by saying that what are we learning right now, and what we're getting to understand is the usual process of infection, viral reproduction, and then we are mounting an immune response. Right, and then patients who are convalescent, they eliminate that virus, right? And what we've spoken about, what Dr. Abubakar is speaking about is, right, what are we really trying to find out on our testing objectives, right? The first question is a person currently infected with SARS-CoV-2, right? Or has a person previously been infected with SARS-CoV-2? Right. And then this speaks to obviously what the nucleic acid amplification tests for viral RNA and where they fit in terms of being able to inform an individual of their infectious status. And I think we've been given clear understanding of this molecular testing. Then on the antibody testing component, right? It provides an opportunity for us to identify, those patients that have been exposed to SARS-CoV-2, and if with the neutralization tests that Dr. Abubakar was talking about, maybe be able to pick up on those that have neutralizing antibodies. After all, I think we are always keen when you have such an infectious disease to get to the level of herd immunity where, a great proportion of people have or immunity to this infection, and therefore protecting those who don't, right? So I'm just going to go quickly through the components. So the question was, what was the target for the SARS-CoV-2 your antibodies, and we've seen this picture so many times, and we're pretty clear, where this lies. But what we know is, detection of host immune response. We get these antibodies to see to the spike protein, but also get antibodies to the nucleocapsid N protein as well, and from so in different tests or antibody tests, considering antibodies either specific for the spike protein or those specific to the nucleocapsid protein. From a Roche perspective, they looked at 46 epitopes around this nucleocapsid and finally found one that was very, very specific for SARS-CoV-2, and then that is the source of the antibodies. I'll just want to highlight here, I think Dr. Abubakar did a great job for us to understand that, the detectability on swabs when we're doing our nucleic acid testing, right, decreases as the infection either descends deeper into the lungs, and that's why I refer to maybe you need to do a bronchoalveolar lavage, use sputum for that test, or when a patient recovers because they're no longer shedding the virus, then if you do a nasopharyngeal swab, you're not going to be able to pick it up. But what we're beginning to find is that this mounting of an immune response starts to happen, day 5, day 6, day 7. And as Prof. Anzala spoke, we expect IgM first and then IgG as your immune system gets more mature. But what's been coming clear in COVID is that there is this variability whereby sometimes, as he said, on day 10, he found IgG, not IgM, or both IgG and IgM come at exactly the same time, right? So because of that, so what we know currently, right, is that in 29 patients that we looked at was that, so here we found an IgM seroconversion started to increase quickly from about day 8, then IgG from about day 10 post-symptom, and they were still detectable 30 days afterwards, right? But then the current data suggests that the levels in chronological order of IgM and IgG antibody appearance are highly variable. And obviously, I mean, just the objectives here, just to highlight, as spoken already by Dr. Barker, is that serological assays, that accurately assess prior infection will be essential for epidemiological studies, ongoing surveillance, and or vaccine studies. I'll just touch on that in subsequent slides. Here is, where I just want to highlight when we talk about epidemiological screening. There is a lot we don't know about coronavirus in our population. There is the talk of 80% of people being asymptomatic, right? And we don't know the viral dynamics within different populations. Have people been infected and we did not know about it? And this is an opportunity if we're to employ and use serological testing purely at that level. And then the other question is, if you're dealing with this high levels of, the chronological order of your IgM and IgG is highly variable, right? Then it would make sense to target both antibodies simultaneously, and this might realize a benefit of increased sensitivity. So I refer here to a publication by Sun and his team, where they found that when they did a joint detection of nucleocaspid IgM and nucleocaspid IgG, or nucleocaspid IgG and spike protein IgG, that they could detect up to 94.7% of infections in the second week. So here, and I'll give an example from a Roche perspective. We're looking at an antibody test that will, a qualitative, by the way, test. As you are well aware, all antibody tests that are available right now are all qualitative, that you can detect either your IgM or IgG, and it's clear that it increases the sensitivity, right? Another point I wanted to make clear here is that, when we're considerations for testing for SARS-CoV2, antibody maturity is really important. As you're well aware, once you start to mount an immune response, you may have immature or initial antibodies being produced, and these do not effectively recognize the virus, right? And this is an early infective stage. When you get to more mature antibodies, these are recognizing the virus, and your host memory for the virus for future recognition then appears. But what I want to highlight is that if we're considering any neutralizing antibodies, neutralized antibodies are a subset of mature antibodies. So if you are having a test platform that provides for antibody testing of mature antibodies, Okta and his team in the Netherlands found a good correlation between having mature antibodies being tested and correlation with neutralization. But as I said, this is just correlation. Then just some data points. I just selected this because I just wanted to highlight, particularly for those who may be, considering validations, in that how we know now that you have to mount an immune response. You have to get the seroconversion happening. And the data has shown us, the periods in early phase, getting to your mid phase for infection, and later on, your ability to pick up these antibodies gradually increases. And this is what the data has shown us here. And this is an example of the Roche Elixis anti-CoV2 data. And it shows that here, for instance, at 14 days plus post-PCR confirmation, there was a sensitivity of about 100%. But all this was gradually increasing from 65 in the early on days. And I think what I want to highlight at the bottom here was that specificity was also considered, and Dr. Abubakar clearly highlighted the potential problems we may see regarding the cross-reactivity with our endemic coronaviruses, right? And in this case, a panel was run with 40 samples of these endemic coronaviruses, and to this point, in speaking particularly for this test, we have not seen yet any cross-reactivity. So speaking to the specificity of this epitope. And I think I won't talk much about this, but it's just to say Public Health England, for example, also did a validation. And what I want to highlight is when you look at sensitivity, again, you see when the antibody testing, you get a gradual increase in terms of the sensitivity as you go on, days after symptom onset. And interestingly was that, this sensitivity rose from 21 days post-symptom onset to from 87% to about 100%, 40 days post-symptom onset, and this is particularly for the Elixis test, showing then that this Elixis test is really picking up on those mature antibodies that I've referred to earlier. And so we've talked about antibody tests, and clearly in the context of surveillance, clearly in trying to understand the disease dynamics, we can look at special populations, whether it's the people in healthcare setting, whether they've been exposed already, and we can look, if there are any hotspots of infection, then there's a possibility there to try and find out if there are any people there who have been exposed, right? So right now, there's a lot of work being done, and in terms of trying to get the evidence around this immunity passport idea. And as more data comes out from the, more than just a correlation of these antibodies to neutralizing antibodies, as more data comes out clearly, then we can be in a position to be issuing such, such immunity passports, for instance. But another role is to help maybe complement nucleic acid testing in the diagnosis of acute infections. It was a talk about, some instances of false negatives on nucleic acid testing, and whether it's a sample collection, whether it's the fact that the disease is now more causing a severe pneumonitis and you are still using it as a pharyngeal swab and not getting enough, then maybe at that point, antibody tests may complement that. And then I think the last part I just want to mention is that, the therapeutics and vaccines, we're anticipating a lot of vaccines. And if you have an antibody testing, you may be able then to single out those who have been exposed to those who haven't, in order for us to start working on those, vaccines. And then, if you'll indulge me, the last thing I'm going to mention is I'm sure we've all seen this so many times, where we talk about this natural history of the disease versus our response to infection. So we understand in early stages, getting this viral response phase that we talked about, with the virus is reproducing. The clinical symptoms are highlighted here, where you get your mild constitutional symptoms. In those, we get the symptoms. And then we go to stage 2, where we start to see the host inflammatory response, right? And then in this host inflammatory response, that's when, as I said, we're being able to start to pick up on those antibodies. But the reason I put this slide up here was to show what has been, with this host inflammatory response, especially when you get this hyperinflammation. And since we're still talking about the whole COVID space and inclusive of other testing parameters, is that, several inflammatory markers have now come clearly, like interleukin-6 as prognostic factors for for poor outcome in patients who start to have elevations in interleukin-6, for example, and that means that in our whole patient management, there are other assets that we need to also start to think about to give this appropriate management. Then the rest of it really just looks at potential therapies. We are all aware we don't have one that is really, remdesivir has some good data, but we're still waiting to find, an appropriate therapeutic response and vaccine. I will stop here, and I thank you for your time.
Thank you very much, Dr. Michael, for the powerful presentation. I think we've gone deep into science just to understand why serology, why molecular, and what are the issues that are involved when somebody is trying to choose a testing strategy. So at this particular point, I want to thank all the panelists who came on board, at least to present and also to shed some light on what's happening in terms of testing strategies that we have for COVID, especially in Africa. At least we've got a very good experience from South Africa from Dr. Michael, and we've also seen our experts from Kenya also elaborate what the issues are. So it's now the time for the participants to just ask questions. We have a Q&A tab at the bottom. I hope majority of you have been able to post your questions. So we are two moderators for this particular webinar, and I would like to hand over to Francis to be able to handle first part of question and answer, and then I'll be able to take over the second part. Karibu,
right.
Francis.
Thank you. I think we have roughly about 34 minutes. We may not be able to answer all the questions because quite a number have been raised in the Q&A section, and I thank you all for raising the questions. So I'll just go straight over to, according to the order of the speaker, and starting with Professor Nzala. A couple of questions have been raised to you. The first one was that WHO has published that asymptomatic spread of coronavirus is very rare. And one of the key responses is to focus on detecting and isolating infected people with symptoms. What are your thoughts on this new finding and advice?
Thank you for the question. You see, part of the difficulty is that in all my academic career, I have never seen a virus that has elicited such a number of publications. And part of the difficulty here is also that a lot of these things are opinions. These things are opinions, not really based on any proper fact. And that's why you have seen a lot of retractions. You guys just saw the other day, the big study on hydroxychloroquine was actually withdrawn, and it had been published in some of the best journals. So I saw that information as well. But as far as I'm concerned, really, it's hard at this point in time because I don't have available to me any sufficient data that has actually looked at to say that asymptomatic individuals are actually can't transmit virus. And then number two, as we understand and look at the natural history of COVID as it is now, asymptomatic is not a steady state. Somebody can be asymptomatic today, and then by tomorrow or in another 2 days, they actually begin to develop symptoms. At this point in time, even if we test you for COVID and we find you positive, we don't have a biomarker. We don't have any biological marker that will say you will remain asymptomatic throughout, and you are the person will actually progress to develop various symptoms. Then number two, just a little bit of the studies that we have actually begun to do here, looking at patients who are in an isolation facility, we find very mild symptoms. So these individuals are not purely asymptomatic. There's a bit of a cough here, there's a bit of a fever there that comes and actually goes. So what I will say now that really provide me with some sufficient data to show that asymptomatics don't shed virus, but at the same time, let us get us to know asymptomatic is not a defined steady state. these patients can move from maybe a mild cough to no cough, a mild cough to no cough, up to 14 days or maybe 21 days. And then maybe now they actually be able to clear the virus. For now, our position, and I believe Mao will agree with me, our position will still be that asymptomatics, as far as we are concerned, are still infectious, and we shall still use that to inform the outbreak as we gather our own data, and we also look at data that has been gathered elsewhere that will actually inform the change in that position. Thank you.
Thank you so much, Prof. Nzala, for that very well elaborated answer. The next question, which I'll just quickly jump into, is, have we had any study in Kenya to establish whether our deaths are from COVID-19 or with COVID-19? And I'll just ask you to answer about 2 or 3 at the same time. And then what do you think of about antibody tests to just indicate how many have been infected in the community? And they also say that they agree with Prof. Nzala that testing of restaurant workers won't help in any way. I don't know if you can pick those 2 questions first.
The issue is the use of serology to how many people have been infected.
There's that one, and also whether is any study to show whether deaths are from COVID-19 or with COVID-19, I guess at the pathology level.
Okay, what we know is that so far the biggest mortality has actually been from Mombasa. That is one. Then number 2, nearly all these individuals who have passed away have had one comorbidity or the other. But we can tell you here and now that these patients had COVID, these patients had severe respiratory distress. Some of them were intubated, all right? A number of them were on, all these aspects that majority of them were in ICU. 1 or 2 actually passed away prior to actually being admitted, and diagnosis was done on post-mortem. So we can confirm here that all the deaths that have passed away were actually COVID related, but nearly all of them had a comorbidity, including the 1 or 2 pediatric cases that passed away. Then number 2 is the issue of testing. I am still trying to reconcile myself with serological testing. Just to ask myself, if I went out there and tested maybe 100 people and found that 50 have antibodies to SARS-CoV2, what next? So what next? I'm still trying to figure out how I would like to use that information. It's not clear in my mind yet. Maybe Matilu Mwau can assist me, but that's what I'm still trying to find out, because I come from the school of thought is that everything we do must be for a reason. Because for one, as far as I'm concerned now, the presence of an antibody at this point in time is not clear, whether it is a protective antibody or just a binding antibody. So that is the approach we must have. Or are we just trying to tell people, oh, you have SARS-CoV antibodies, then what does it mean? Because that will be the next question the individual asks me. So I have antibodies, yes. I was exposed, yes. So what does it mean? Does it mean that I'm less susceptible now? Does it mean I'm protected now? So I want to be able to do a test and have a reason to tell that person what that test means at an individual level, but also to use that test to inform how we are going to respond to the COVID outbreak as we have it now. Maybe later on, January, when really the true decline is down, then we can say, oh, we can go back and compare. And also let's ask ourselves, I don't know whether Mwau has, but I don't have any data to show at what percentage of us have actually antibodies to the 4 common coronaviruses at any one time. So those are things that we really want to understand, because part of it is that eventually this virus will either mutate itself out, or it was going to go the Mers-CoV way and become endemic. Now, once it becomes endemic and there is a vaccine, and we know maybe it will be like an influenza vaccine where you have to give it or not. So really, the issue here is that the science is slowly becoming clear. But everything that we have to do, because these things cost money to research, they cost money to the patient, we must figure out what we do. So my question is that, so if you have antibodies at this point in time of SARS-CoV-2, what do they mean to you as an individual, and what they mean to the outbreak as a whole? Those are the issues that I would also like to hear from the participants. Thank you.
Thank you so much, Prof. Nzala. Maybe I'll just move quickly to Prof. Mau to just also comment on the issues raised by Prof. Nzala, and then he can pick up the next 2-3 questions.
Thank you. Thank you very much. I just have 2 general remarks. The first one is about the asymptomatic people not spreading coronavirus. The WHO made such a comment quite recently, but just this morning, I saw a paper published by Oran and others in the Annals of Internal Medicine, which said that asymptomatic people could continue spreading coronavirus for a substantial amount of time, even more than 14 days, with that lack of symptoms that they have. And therefore, I should just say that, you know very well, very few people have understood coronavirus well enough. WHO has misstepped severally this time, and they have made genuine errors, because we know so little about this thing, even about antibodies, we know so little. And it's still early days for us in Kenya to use that judgment to try to inform public policy. I think we need to be patient. There are some countries that are ahead of us in the curve, and the lessons that they learn, we will translate them. If they decide to implement this approach, we will see and learn from it. It's still early days for us. The second thing I want to say is that I was informed last week of a very nice study another researcher at the Wellcome Trust in Kilifi did, called George Warimwe, and he looked at the presence of antibodies to coronavirus in blood donors in the coast recently. And he had actually developed that antibody test himself. And he found that I think about 12% or something of those blood donors had got antibodies to coronavirus, and he thought it was SARS coronavirus. So my question to you would be, so should we round up these guys who have these antibodies and lock them up, or we should just let them go home? Because after all, they came peacefully to just donate blood. But I'm willing to answer the questions that you have for me going forward. So you might as well ask. Thank you.
All right. Thanks, Prof. Maybe you can take a few quick ones on, especially around the lab testing. The first one is, what's the position on the use of GenExpert machines and technology, considering the availability in every country to assist in mass testing countrywide?
Oh, I could answer that straight away as you think of the other one. In Kenya, there are 189 GenExpert machines in sub-county hospitals and county hospitals, but not all of them, but more than 2/3 of those big hospitals. Those GenExpert machines could either be 4 module, in other words, they can run 4 tests at once, or they could be 16 module. They could run many tests at once, 16. The 16 module GenExpert machine could probably do something like a maximum of 80 tests per day, and the 4 module one could even do 20. In this coronavirus response, we went around to all the facilities to look and see whether the GenExpert machines, which are currently in use for TB and some for HIV, could be brought into play with regard to coronavirus. And we found that 59 of them could be, because they were okay, they were functioning, they had biosafety cabinets next to them, and the people who are using them knew what they were doing, and they knew where to throw the waste when the waste comes. Then we went ahead and looked at the budget and decided that we have to buy GenExpert reagents. We have not yet bought them. there were some reagents that were expected from the IOM, but in the Global Fund, we put a request for that 9,000 gene expert cartridges and the accessories that are required for tests for coronavirus. When those come, they'll be distributed to 57 machines. We've already done the allocation, and therefore it is possible that we can actually use this testing for the counties, unless the counties become overwhelmed, in which case now we are not able to, we'd have to use the reference laboratories. Thank you.
All right. Thank you, Prof. I'll ask you maybe to answer a very quick one, just around about the hospital patients with symptoms, vulnerable populations such as old and populations with underlying conditions. I don't know whether you could address that one.
Yeah, so as far as I'm concerned, the big trouble I have is with regard to sending people to a health facility and putting them there. And that's why I like isolation a little bit, but not too much either. But the people who are in hospital must be protected completely from people who might have coronavirus, okay? But in any case, if somebody has got signs and symptoms that are suggestive of something chest, a pneumonia, upper respiratory tract infection, at this time, or meets the case definition for coronavirus, that's the kind of person who should be tested. But I'm a bit 50-50 about a person who is in hospital for a particular purpose. Maybe the person is dialysis, let's say, has no issues, has not been in contact with anybody, and there's no reason to suspect they have been exposed to coronavirus. I have a PCR test with myself that costs, let's say, 3,000 to 4,000 shillings, and then I want to use it on that person. No, let's test for a reason. Thank you.
All right, then a very quick one for you, whether PCR tests can detect a dead virus. Is it possible?
Yeah, a virus is not a living thing. A virus is it's not like an organism, the way in the classic sense. A virus is like a chemical package. So, so PCR tests for this, like if you are looking at RNA is like a molecule. It's not like a living thing. So yes, we will find them and we will test and we will find they are positive.
Okay, thank you for that. I think the question around
just a minute. Mwau,
Yes.
I think that question from Mwau is informed by what we have been finding, where we find people shedding virus for even 40 days, and whether that virus is infectious or not. That's why you hear people referring to it as a dead virus. So long prolonged periods of shedding. So what you can really maybe talk a little bit is that how in science, how do we know that a virus is infectious or a virus is not infectious? Because we are just looking at the genome and not the virus itself. I think maybe that's what it alludes to. Maybe you can talk a little bit about that.
For the purposes of this audience, maybe what I should say is that some of those particles that are being shed, what we are finding is that they are not infectious at all. And in fact, in a layman's language, they are incomplete, okay? It doesn't mean they were living at some time and they got dead, but some chemical, something happened to them. And Anzala here, you can come in a layman's language, yeah? They are not infectious at all, actually, but we do not know what proportion of the people will be secreting non-infectious particles and those that will be secreting infectious ones. It's still early days.
Ladies and gentlemen, that is now the critical balance of what criteria do we use to discharge somebody. And it's a virus that you cannot just pick a sample and grow this virus in a level 1 or level 2 lab. And it was critically said here that to be able to do that, you need a level 3 lab. So we are still looking at that, but Cambridge can be able to do that. But those are the studies that even in our own environment, we will like to, to find out how long indeed do people shed culturable virus that is actually infectious. So this information is becoming available, but we also want that information in our own setting to inform us now, but also in the future. Thank you.
Thank you. In the interest of time, I'll just ask Professor Matilu one more question. What are you doing to ensure that you are giving confidence to Mwananchi, government, and other interested parties that you are channeling out the right results?
Oh, in terms of creating the right results and being confident with the accuracy of what it is that we are doing, we have both internal and external quality assurance systems that are in place now. We even have panels being sent by some of our partners that we use to check that our labs are providing results that are accurate. With regard to whether we are telling Mwananchi that this is a thing, maybe this is the kind of forum I should use to assure Mwananchi that in fact, the labs even have some quality assurance relationships between themselves, where they send each other samples, they send each other panels, and we're also receiving panels from elsewhere. And so far, the level of skill that we have implemented in testing for coronavirus should give you the confidence that the results we give you actually mean something for you. But as to whether we can go out to the media, when the day we'll get an opportunity, we'll make very loud noise that we know what we are doing. Thank you.
Okay, thank you so much, Prof. Matilu. I'll go back to Prof. Adzala to just answer one burning question. Is there any strategy being considered to map the extent of spread in the country via serology? And could this better inform the interventions?
It is okay to map out using serology.
Yes.
The question is to map out the prevalence
spread
of serological tests. The
spread, yes, in the country using serological tests.
You see, there are two aspects, as was clearly articulated here. At this point in time, the serological test will actually be tests that are telling you post recovery that you are actually at one time infected and you recovered, and now you have antibodies to SARS-CoV2. Now, the issue is that at this point in time, we will want very, very clear, very well validated tests within our own environment, because I hear people say, oh, these tests have been validated in the US, or these tests have been validated in Europe. Our population, ladies and gentlemen, is very different. It's very, very different when it comes to immunology. So these tests must also be validated here before we can even begin to use them. We are seriously, actually Professor Matilu is validating a number of antibody assays. Once we have one that is clear, then the issue we shall ask ourselves, do we want to do point prevalence just to find out what percentages in various communities have antibodies to SARS-CoV-2? And then, as Mo clearly said, if they do, what does it mean and how will you use that information? So it is something that we are actually beginning to think through, because we don't want to tell anyone that if you have antibodies, you are protected, or you are less susceptible, because we have also seen in other countries people stop shedding, they are discharged. Within 3 or 4 weeks, they begin shedding again virus. So we don't know whether it is a rebound, whether the infection remained hidden somewhere, or whether these guys have been reinfected. So these are issues that we must first of all know before we can actually advise communities and advise the outbreak how we really want to use this test. So I cannot say that we can go out there and do mass serology. The whole issue, and my position with Mwau is clear, we must test for a reason. I still maintain that. Thank you.
Thank you very much, Prof. Thank you, both of you, Prof, for your really good answers to the questions. There are so many raised, but because we only have about 11 minutes, maybe we'll allow the other panelists to also answer a few questions. So let me hand over back to Anthony to just take a few of the questions for Dr. Abubakar and Michael Reid and Dennis.
Thank you very much, Francis, for that session for Q&A. I have only maybe 10 minutes just to also pass through this to other panelists. So the first question goes to Dennis. Is IQC enough for assuring confidence in testing? I think it had been answered partially, but maybe you can just jump in a bit. Yes, Dennis?
So for quality control measures, we have various ways of ensuring that the quality indicators are met. So one is usually also, you can do a lot-to-lot validation of the kits. When you receive a new kit, you use non-positives and non-negatives to see if there's replication. Apart from the IQC, there's also the interlab testing. Remember, within Cambridge, we have almost, I think, 6 labs. So we've done an interlab testing with the Kisumu lab, where we've sent them positives and negatives, and then they've tested on their end, and we've also done the same here from what they tested from Kisumu. So that one gives us confidence that whatever we are giving out, the results we get and give out are actually 100% correct.
Okay, thank you very much for that answer, Dennis. So you can, or just to embed that, there are also now EQA services for COVID. There's QCMD from Roche, from Randox, sorry, that can also be available in the country and the rest. The other question I would like to be answered by Dr. Michael. There's a question that, can a panelist mention on the integrity of test kits, like the case scenario we saw in Tanzania? Could you just maybe speak to the integrity of test kits? There are a lot of analogies going around that some are already having COVID virus embedded in them, and therefore that high positivity rate in Tanzania. So maybe Dr. Michael.
No, thank you for that question. I think, I mean, I've seen a lot of anecdotes, come along those lines. I think there was also a big hurrah that happened in the UK as well. I think, on my side, at least on my position, would only be to speak maybe from, entirely Roche perspective, where, quality and quality control is key to what we do at Roche, and particularly in the integrity thereof, right? Because at the end of the day, whatever test that you are getting access to, you want something that provides for you the confidence that you are surely getting what it is that you want. And and in a situation of such a pandemic, whereby we as Roche are responding to this massive pandemic global. I mean, you see, we started off towards the end of January with our partner T-Mobile by developing a PCR test. And then by the 13th of March, we had our own PCR test that's on our 68 and 8800 machines. That's, there's a lot of, as I said, a lot of quality control, and we have a long pedigree on our side in the PCR, testing realm or molecular testing realm from the mid 80s, early 80s to mid 80s. So there's that, from our side. But to speak directly to some of the integrity that, and the other, maybe ethical issues that may have come out of those anecdotes, I won't be able to really speak to that, unfortunately. It would be quite interesting to actually bring out those particular kind of tests. And that's why I like how Prof. Anzala always highlights the need to do own validation and not to use somebody else's data, but to always stick onto the local data and confidence, and provide more confidence in the particular test. Yeah, thanks.
Thanks very much. I think the validation is key. The laboratories, as much as you receive kits from all the donors or from all the vendors, should be able to validate them to ensure that they're performing what they're intended to do. The other question I'll throw it to Dr. Abubakar is that I know there are some of the closed systems normally have challenges of contamination, and you realize this when everything starts turning positive or even negative in the long run. What are the worst fears as far as contamination is concerned?
So this is contamination in regards to the closed systems, or just contamination in PCR in general?
Contamination in regards to closed systems, and maybe you can just elaborate further.
Okay, so I think to overcome the whole contamination issue or carryover, molecular testing is a bit more technical as compared to the other testing, and you need to know that the technologist or whoever is carrying out the testing is someone who's trained in carrying out molecular testing. And as part of quality from the lab side, also you need to be sure of the competency of the people carrying out the testing and also interpreting the testing. And you should be carrying out competency testing every so often. We can determine the either twice annually or once annually that you're doing competency testing for whoever is carrying out or interpreting the testing, so that you don't have issues of carryover or contamination, because that stems from the competency of the person carrying out the testing, because it's mostly either falls in pipetting or in how you set up your testing, whether you're doing correct pipetting actions, or in terms of, say, the controls, the negative and positive control, are you setting them up as is required so that you reduce the chances of contamination from your positive to your negative control? So it mostly has to do with the competencies of the people carrying out the testing and also people interpreting the results. So in case you have, say, a positive result with a very low CT, that's it's indicative of a very high viral load. And the next sample to it is a test with a very high CT. And depending on either, so this is in general in PCR, it doesn't have to do with COVID only. You can then look at the clinical and other data to see what, because there's a likelihood that there's carryover from the very low CT to the high CT sample. And there are mitigations for that. Either you decide that such samples will be repeated to see if it was a result of carryover. So there are mitigations to all of this that can be set in the lab to account for all that. I don't know if anyone else can add on to that.
I think also for the contamination issues, like part of the standard protocol, like for us, what we do is once in a while, like once every month, we swab the lab and just run to see if maybe we have a contaminant somewhere. So those are things that you put in place that help you monitor. As you work, you keep in check so that whatever is happening, you know, if there's contamination, you deal with it before it spreads so much in the lab.
Yes, and also forget the decontamination with RNSs every so. Sorry. Decontamination using RNSs on the surfaces as you're carrying out your daily routines, your PCR runs in the molecular lab.
Okay. Thank you very much for that response. Just a last burning question is to do with, I'm going to throw it to Professor Matilda Mwao. What process does it involve a private laboratory to get us accredited or certified for testing COVID-19?
So thank you very much for that question. So the first thing is to approach either the National Public Health Laboratory Services, for instance, the Department of Laboratory Services at the Ministry of Health, or the Director General at the Ministry of Health, and express your interest in testing for coronavirus. Then a team will be sent into your lab and will do some checking to see whether you have the systems and the infrastructure and the human resources that it takes. And then eventually at some point, after some back and forth, you'll be given an offer to train your people if that is a requirement and you don't meet it, so that they can understand this, even biosafety or even the testing, the PCR. And then if you pass all these things, then you'll be listed as one of the labs, and then you'll even be able to benefit from some of the national assets that are available. But at the same time, it will be expected that your database, if you have any, will be talking with the national database, because a coronavirus positive person is of interest to every member of the public. So the public health must understand that you are doing work that is of relevance to the whole country. So the databases must talk. If you don't have one, you'll be provided with one. So in summary, you need to approach the National Public Health Laboratory Services or the Director General of Health, and then you'll be guided. Thank you.
Okay, just in the same breath, could you talk a bit about accreditation? How are you working with KENAS to ensure that the COVID test is accredited by KENAS?
No, KENAS. So the labs that are doing testing, some of them, like my labs, for instance, are accredited by KENAS. Accreditation is a very long process, and in fact, if you start asking for accreditation right now for a particular lab, it may be that coronavirus will disappear. I hope it disappears. It may disappear before you finish the accreditation process, right? But in any case, when KENAS comes to you, or the auditors, when they come, sometimes they find that some of the labs that are not accredited are actually following all those processes and procedures that accredited labs do. But it's always nice for you to know that the procedures and the process that you're following are actually a standard, and you're meeting that standard. But a relationship with KENAS takes time to form. The accreditation takes, in our experience, more than a year to 2 years to actually achieve all those requirements. And there's a continuing audit situation so that you remain performing as you should. And it costs a bit of money, and it's a very nice thing to have, because it gives people confidence, even members of the public, that the tests are being run in a lab that knows what it is doing. Thank you.
Thank you very much. I think we've had a very wonderful session with all the panelists. We've been able to share knowledge. We've been able to share experience. And I think the lab fraternity is happy, and also the medical fraternity is happy that at least the gray areas that have been mentioned once in a while have come to light. We're going to have another session next week, same time, so that we're able to have all those follow-up questions that you've been asking addressed. We are also going to have a session on quality and all those particular issues. So I would like to give each and every panelist only maybe 30 seconds to give a parting shot, and then I'll hand it over back to Anastasia and Michael and Francis as well, just to say something, and then we'll be able to be done. So I'll start with Dennis. Dennis, you can give you a parting shot.
I think this has been interactive. I think we've learned a lot from one another, and I'm glad knowledge is being shared out here. Guys are being enlightened, and people know what's going on. Mine is just to say thank you. And yes, Doris, our lab is also accredited with ISO 15189. Thank you guys so much. It's been wonderful.
Thank you very much, Dennis. Thank you for coming on board on a short notice. I'll go to Dr. Bubakar.
Yes, Anthony, thank you for inviting me and having me on the panel. It's been a good discussion. Yes, thank you.
Thank you very much for also just agreeing to come on a short notice. I really appreciate. Dr. Michael?
Yeah, and no, thank you for the time, and I really appreciate the engagement and conversation. I think chief among this, the debate on serology testing will rage a little bit on, and I liked Prof. Nzala coming up and asking about what do I do with this positive test, or what happens next, and I think there's an opportunity there to see how to apply or not apply in a whatever setting that exists. But thank you for the time. This has been a very, very great meeting, and well organized. I appreciate the organizers. Thank you very much.
Thank you very much, Michael. Great experience from South Africa and from Roche. I think we've been able to be educated well. Prof. Matilo Mau?
Thank you. I think this is a very good engagement. I'm quite pleased actually at the level of interaction that is here and the amount of knowledge being shared. I just want to promise everybody that we've just received some test kits, and you might see larger numbers now. Please don't panic. It looks to us as though is an arithmetic relationship between the numbers of tests that we are doing and the number of positives that we are finding. So don't panic if we hear we are saying many. Thank you.
Thank you, Prof, for coming on board and just using your time to be with us. And I think it's really been a real eye-opener and being the face of testing in the country. Yes, Professor Nzala.
Thank you for inviting me. In fact, it's interesting that COVID has made me meet people I would never have met at all.
Karibu sana, you've been the face of extension of the curfew.
It has actually increased my net worth in terms of networking. So it is actually a very good thing. So, and also it has brought up debates in science that we didn't have before, because we thought that everything we see in journals is fact. So I think let's continue with this. Let's open a new chapter where we should be able to interrogate, science at every step and make science work for us. So that's what I'd like to see, though. So I'll also leave by saying that our basic research has actually started. We are recruiting, patients to just understand all the things that we've been talking about, rebound, if there's any rebound, immunology, how long are these antibodies, what kind of antibodies. We are looking at innate immunity, we are looking at T cells, we are looking at if this virus will also behave like Ebola, where we thought when you recover, but Ebola seems to also hide and complicate later on 2, 3, 4, 6, 7 months later. So we are looking at short-term research, but we are also looking at long-term in terms of how things are going to be. So let's all stay engaged. I'm happy. And when you need me, just give me a buzz and then we can continue the discussion. Thank you very much.
Thank you very much, Prof, for the humility and for agreeing to come on short notice. I really appreciate that. And I also want to thank my co-facilitator or co-moderator, Francis. Maybe Francis, you can say something, and then we'll be able to hand it over to Anastasia.
Thank you, Anthony. Mine is just really thank everybody for their participation, especially the panelists, and also the questions which have been raised. Just to give you the assurance that we have recorded down all your questions. Those which have not been answered will definitely be answered in the next session. That's all for me. Thanks.
Thank you very much, Francis. So Anna, the platform is yours.
Thank you, Jacado. Thank you, Francis, for the great forum. Thank you, panelists. Really insightful and educative. I think you have challenged us. I think most of the participants are more than confident that, like Matilda said, we're doing the right thing and we're on the right track. So thank you for putting it out there for us to be aware. And we hope you can join us again on Tuesday, same time. We'll try and make it maybe 1 hour, 1.5, because we will try and as much as possible to take your questions ahead of time. For those who qualify for CPD points, please write to us on covid19@khf.co.ke, and then we'll be able to facilitate the CPD points award. So the session is recorded. We will have it on our KHF YouTube channel, maybe in a day or so. So please stay tuned, and thank you very much, participants, for staying on. Yes, so Amit, I will now hand over to you so that you can close. Sorry about that, Amit. So back to you.
No worries. Before we close, and I know many participants came, we had over 450 professionals. And to Professor Anzala and also Professor Matilu Mwau, I think we need to start engaging on an economic discussion for this country. And when we say testing for a reason, we will need to define a reason. In Kenya, there is a lot of medical, social, political, legal reasons. And these reasons can be drawn out and can take away from the taxpayers' kitty funds that might be useful for livelihood. If we ever miss the balance between livelihood and probably medically necessary, because many of us are very medically inclined, we may have actually eroded the livelihood funds if we don't define the reason. There are very possibilities that we could slip into using the funds ineffectively. So I think an economic discussion is very, very useful. What would be really not, what would be worth discussing is what and how much dollars should we use in buying kits, reagents, HR, time, freight costs, clearing costs, just to make it an academic paper that helps nothing in terms of making our economy grow in Kenya. And like you said, that if it's positive, so what? If it's negative, so what? If we maintain social distancing and managing to reduce the spread, we will have spent so much less money and will have made a prosperity for the future generations or the funds that were there. So an economic discussion is going to probably supersede a laboratory discussion and a theoretical model that might be worth thinking of. I don't know if Professor Mwao, you want to respond, or Professor Nzala, but Anastasia, I think an economic overlay to this scientific discussion might be useful. Prof. Mwao?
Yeah, I'm a scientist, but at this point in time, this is the first time in my life I actually feel reasonably or gainfully employed, because I'm thinking about service more than science for the first time. And to be honest, we must ask ourselves these questions. And of course, there's the part for academia where we excel. And the questions around the economics and around cost benefit and so on are things that we'll look at. But we are clever enough to know, straightforward, every coin we throw at a test must actually be for a reason, okay? But the academic questions are things that we'll continue struggling with, and you might see very nice papers, but those ones are things that will come after you've gotten on top of this coronavirus.
Very interesting. Professor?
I totally concur with you. I concur with you, Amit. I concur with Professor Matilu Mwao. It's really a discussion we must have, but also not just for COVID, but a discussion that we must have as we go forward. COVID will eventually subside, but the whole issue of testing patients for this or the other will continue. So let's use COVID as a platform to relook at ourselves and ask ourselves exactly the question, Amit, you are talking about. Thank you.
Thank you.
Amazing.
Anastasia, over to you.
Yes, sir. You just shaped up our topic for next week on Tuesday. So we'll be calling upon Professor Matilu Mwao, Professor Nzala, and the rest of the panelists. Yourself, Amit, because we need you to talk about the economic aspect, and maybe somebody from KEPSA. But that I leave it to the moderators to put it together. Otherwise, from me and from the entire Kenya Healthcare Federation team is to say thank you very much, and we wish you all the best, and we will support you as much as we can, and we continue to engage. Thank you, and have a good rest of the day.